Hi, everybody. Thank you for coming to the last session of the day. My name is Martin King. I'm going to be talking about advances in rectal spacing for prostate cancer. I'm a director of GU Radiation Oncology and associate professor at the Dana-Farber Brigham Cancer Center in Boston, Massachusetts. I do have a couple of disclosures. Number one was I was the coordinating investigator of the Barrigel randomized controlled trial for Teleflex. I have also received research funding from Bayer Healthcare. Here's the outline of my talk. I'll give an introduction to rectal spacing, talk about the prospective evidence for rectal spacing, discuss some controversies about rectal spacing, and finally, provide some overall general recommendations for rectal spacing. So there are 3 different rectal spacing products that are FDA approved in the United States. The first product that came to market was the Space OAR Hydrogel. This is a device. It's made of polyethylene glycol. There's basically 2 solutions that are mixed together in real time during injection through a needle, and the product is deposited between the prostate and the rectum. And so in the top image on the right, you can see that there is the prostate and the rectum. For this patient who is quite thin, there's no space between the prostate and the rectum. And in the bottom image, this is the image of the prostate, the rectum, and the hydrogel spacer in between. There's been a second product that has come to market, and this product is called Barrigel. Barrigel is made of hyaluronic acid. This is the same substance that is often utilized for facial fillers for plastic surgery procedures. Barrigel comes in as a single syringe. Each syringe is about 3 milliliters, and like Space OAR, it is inserted into the space between the prostate and the rectum. You can see in this picture right up here, this is the axial image. You can see the prostate, the rectum, the Barrigel. And then this is an image on sagittal. You can see the prostate, the rectum, and the Barrigel, allowing for separation along the entire axis of the prostate. The last FDA-approved device is called BioProtect. This is a device that was FDA-approved recently, and it's basically a balloon that is filled with saline and inserted between the prostate and the rectum. This is an image of the device, and this is an image of the device on MRI, where you can see the prostate, the rectum, and the balloon, causing good separation of the prostate and the rectum along the entire axis of the prostate. So what is the workflow for getting the rectal spacer into the patient? So originally, we have the original anatomy. In the original anatomy, as shown in the images here, you can see the prostate and the rectum, and then this is called the non-villous fascia. And this area can vary in size based on a patient's anatomy. What happens is that when the spacer is introduced, the spacer is placed between the prostate and the rectum. This is done in the procedure that I'll discuss later, and it's often done at the same time of fiducial marker placement. And as we all know, fiducial markers are often placed for patients undergoing definitive radiation therapy for prostate cancer. Once the spacer is inserted and the fiducials are inserted, the patient undergoes a simulation scan. We often use a CT simulation scan, but also an MRI simulation scan. And the MRI simulation scan can be important if you use a spacer that doesn't have contrast in place between the prostate and the rectum. There are some spacers, such as SpacerView, where it does have iodinated contrast, and in those cases, you probably only need a CT. but in many other cases, both the CT and MRI are helpful. The final step is treatment planning and then treatment delivery. So how is the spacer actually placed? First of all, the patient undergoes anesthesia. Anesthesia can be optional, but often can help improve the patient's comfort level and also decrease the chance or increase the chance that the spacer is placed in the correct position. The patient is then placed in dorsal lithotomy position with the legs up. The transrectal ultrasound probe is inserted into the rectum. Under transrectal ultrasound guidance, you can see the anatomy of the prostate very clearly, and it's at this time that the fiducial markers are inserted into the prostate in a manner that is through the perineum. Once the fiducial markers are in place, then the spacer apparatus is prepared. Hydrodissection can be performed. This is an optional procedure. For Barrigel, it is required for space OAR, and then the spacer is inserted. This is an image of the space OAR apparatus in which the needle is inserted, in which there's 2 syringes onto a Y connector through the needle, and when the plunger is pushed, the hydrogel is placed between the prostate and the rectal wall under ultrasound guidance. This is just a closer picture of the anatomy. Basically, when the needle is inserted, and this is done after fiducial markers are placed, the needles are inserted about 1 to 2 centimeters above the probe through the perineum. The bevel is faced down, so the needle, the pointy end, is actually faced up. The needle is placed over the rectal hump, and so we don't want to get the needle through the rectal hump because that might increase the chance of a rectal wall infiltration. Once this needle is in place, it is threaded through into the perirectal fat, and it's of utmost importance to try to minimize the chance that the needle touches the rectum. The needle can touch the prostate, but we don't want it to touch the rectum. This is an image of the needle in place. This is an axial image. You can verify the position of the needle. This is for the Barrigel insertion. What you can do is you can put a small 0.5 cc puff of the Barrigel, and you can see that it's actually separating between the prostate and the rectum. And then you can also once you verify the position on the axial position, you can actually put more Barrigel in and then switch to sagittal. There's different ways of inserting Barrigel. You can put the Barrigel under the seminal vesicles and then move more proximally so that you get good separation for the seminal vesicles all the way down to the apex. Then what happens is that the patient undergoes the CT and MR simulation. So this is the CT image. You can see the fiducial markers in place. You can see where the prostate is. And in this case, for this patient who received the Barrigel, you can actually see where the rectal spacer or prostate interface very clearly. And this is really where the MRI is helpful. As you can see, the spacer is T2 hyperintense on MRI. And so here you can have good definition of the prostate, the spacer, and the rectum. Then the patient undergoes treatment planning, and in this particular case, we're able to minimize the chance that the 90% isodose line crosses the rectum. And you can see that there is some crossing for the 50% isodose line, but the 100% isodose line, the 90% isodose line, does not cross into the rectum. As you can see, we're able to meet all of our metrics, and this is done on our Ethos machine. And we're able to really, really minimize the amount of dose to the rectum. So what is the prospective evidence for rectal spacing? So currently there are 3 randomized trials for the rectal spacer. One is with the Space OAR polyethylene glycol, and this was the first product onto the market. This was a randomized study 222 patients over 20 centers. Patients had low or intermediate risk prostate cancer. All patients received conventionally fractionated radiation therapy, 79.2 gray and 44 fraction. The primary endpoint was a dosimetric endpoint, and 97.3% of patients achieved a greater than 25% reduction in the rectal V90%, or what we call the rectal V70, which is 90% of 79.2 gray. What about the clinical endpoints? When they looked at the data at 3 months, they did not see the spacer was not associated with reduced acute rectal or urinary toxicity. This can be visualized on the top row here, where the proportion of patients with grade 0, grade 1, or grade 2 rectal toxicity was similar across both arms. P-value is 0.525. But when they looked at late toxicity, which in this case, in this publication, was defined as between 3 to 15 months, they were able to see that the rectal spacer was associated with a decreased amount of toxicity. In the control arm, there were 5 grade 1 or higher toxicities. In the spacer arm, there was only 3 toxicities, or 2%, and the p-value was significant. They also looked at the quality of life. And in this study, they saw that fewer patients who received the rectal spacer had a clinically significant decline in bowel quality of life at 15 months. There was no difference in the percentage of patients who experienced clinically significant decline in urinary quality of life. And so really what this suggested was that there was better bowel quality of life for patients who received the rectal spacer at a 5-point cutoff or a 10-point cutoff. They've also looked at the spacer trial out to 36 months. What they did see was that the spacer actually reduced rectal toxicity, both grade 1 and grade 2 or higher rectal toxicity. There was no significant difference in terms of late grade 2 or higher urinary toxicity. They also looked at the bowel quality of life. What they found was that fewer patients who received the rectal spacer had a clinically significant or 5-point decline at 36 months, and you can see this big, nice separation at 36 months. There was no significant difference for urinary quality of life at 5 points, although maybe there is somewhat of a signal for a difference at with a 10-point cutoff. The rectal spacer was not associated with with a difference in sexual or hormonal quality of life, but the rectal spacer was associated with less dose to the penile bulb. We have also had a second randomized trial. This was the Barrigel randomized trial of hyaluronic acid. This study included 201 patients at 12 centers, and they were randomized. They were also similar, low or intermediate risk prostate cancer. Unlike the prior trial, all patients had hypofractionated radiation therapy, 60 gray over 20 fractions. ADT was allowed, and so 30% of patients received a 4-month course of ADT. And in terms of the primary dosimetric endpoint, 98.5% of patients achieved a greater than 25% reduction in the rectal V90%. Why do we choose to look at hypofractionated radiation therapy? In a large meta-analysis of phase 3 randomized controlled trials, there was a report that hypofractionated radiation therapy was associated with a greater incidence of acute grade 2 or higher rectal toxicity compared with conventionally fractionated radiation therapy. So as you can see here, the risk difference was about 9.1% when we looked across these trials. So for this trial, we defined a key secondary endpoint, and we wanted to show whether the spacer was associated with non-inferior acute grade 2 or higher GI side effects compared to control. We defined a non-inferiority margin of 10%. What we were able to see was that the rectal spacer was non-inferior compared to the control for grade 2 or higher side effects. It was actually also superior in the sense that the total percentage of patients who had acute grade 2 or higher side effects for the spacer arm was 2.9%, compared with 13.8% for patients on the control arm. The grade 3 toxicity that was observed for the patient who received the rectal spacer was probably associated more to toxicity from radiation therapy rather than the rectal spacer. We also wanted to explore whether fewer patients with the rectal spacer had a minimally clinically important decline in bowel quality of life, and we were not able to show a significant difference for bowel quality of life at the 3-month time point. The observed value was 0.13. 26.5% of patients achieved a minimally clinically important decline on the spacer arm versus 37.7% on the control arm. Because of this, we wanted to evaluate whether certain characteristics with the rectal spacer on post-implant imaging was associated with bowel quality of life at 3 months. So we did a secondary study where we looked at the following metrics on post-implant imaging for patients who received the Barrigel arm. We looked at both spacer symmetry. We also looked at the separation between the prostate and the rectum on a superior plane, the prostate midplane, an inferior plane, and the prostate apex, which is the very, very bottom of the prostate. What we were able to show was that 95.6% of patients had a symmetric implant, and there were 0 slices that had asymmetry. We were also able to show that the prostate volume and apex separation were both associated with the rectal V30 on multivariate analysis. And so you can see here that both of these factors had a p-value that was less than 0.05. We also found that apex separation and baseline EPIC 26 bowel quality of life was associated with change in bowel quality of life between baseline and 3 months. You can see that here where the p-value was less than 0.05. And when we looked at the percentage of patients who achieved a decline in bowel quality of life, the value was 36.6% of patients who had an apex separation less than 10 millimeters. But it was only 14.8% of patients who had an apex separation greater than or equal to 10 millimeters. And this suggests that greater apex separation may be associated with improved bowel quality of life at 3 months from treatment. We can see that here. In the top panel, you can see that this patient had a less than 10 millimeter separation between the prostate and the rectum at the apex, and you can see they're really pretty much contacted here. On the treatment planning scan, the 60 gray isodose line crosses through the rectum on this point here. In the bottom plane, when we looked at this patient who had good separation along the prostate base, midgland, and apex, with the separation that was more than 10 millimeters, you can see that the 60 gray isodose line never crossed through the rectum. Furthermore, there was less volume of the rectum exposed at the 20 gray, 30 gray, 40 gray, 50 gray, and 60 gray isodose lines for patients who had more than 10 millimeter apex separation versus less than 10 millimeters. So what we have found was that the Barrigel was associated with a reduction in grade 2 or higher rectal toxicity for hypofractionated radiation therapy. It did not reduce the percentage of patients achieving a significant decline in bowel quality of life. Bowel quality of life may be associated with improved apical separation, and the 3-year results of the Barrigel randomized trial are pending, with hopefully results coming out later this year or early next year. The final trial that was conducted, this was reported very recently, late last year, was the BioProtect trial. This is the balloon that can be placed between the prostate and the rectum. This trial looked for 222 patients across 16 centers. It allowed patients with clinical T1 and T3 disease, but they could not have posterior radiographic extraprostatic extension. Patients received a standardized 81 gray and 45 fraction, but hypofractionated regimens were allowed. And what they were also able to find was that 97.9% of patients achieved greater than 25% reduction in the rectal V90%. What they found in this study was that there was no difference in rectal or urinary toxicity in the acute time period from 0 to 3 months, the late time period from 3 to 6 months, or the overall time period from 0 to 6 months. There was also no difference in quality of life. Next, I want to talk a little bit about some of the controversies associated with rectal spacing. So one of the points that people often raise is that the rate of rectal toxicity, grade 2 or higher, so what this means is that it's rectal bleeding or the presence of mucus in the blood, mucus in the stools, is actually quite low. And the toxicity rates are low with more contemporary treatment techniques. One of the trials that we can look at is the PACE-B trial. And the PACE-B trial was reported just last year for the 5-year endpoint. The 2-year endpoint was reported just about 3 years ago. And this trial randomized patients with conventional radiation therapy, where the majority received hypofraction radiation therapy or 5-fraction SBRT. What they were able to find was that only about 3 to 4% of patients had grade 2 or higher GI toxicity. And so people argue, do you really need the rectal spacer for patients with conventional techniques? Because nobody on the PACE-B study had the rectal spacer. So I had one case where this was a patient, and he declined the rectal spacer. He was 72 years old. He had Gleason 4+3 disease, so he had unfavorable intermediate risk disease. He received 6 months of ADT. He had modern treatment at that time. So he had online adaptive prostate IMRT. We were doing 60 gray in 20 fractions. We used a 4mm PTV margin, and every day on treatment, we did treatment adaptation in the sense that if his prostate anatomy or SVs changed, we actually changed his treatment plan. What we found was that during the treatment, he actually was not able to complete the treatment. And the reason for that was that he had a lot of daily gas issues. And he was on the table for too long, and our therapist just thought that it was not the right thing for us to do to proceed with the treatment. So for the last 10 fractions, we actually changed his treatment to a non-adaptive plan. We used our standard 5mm margin, and we completed the treatment. When we looked at his dosimetry, his V59 was a little bit higher at 10% than target, but he met all of our metrics. What happened? So at 4 months from radiation therapy, the patient started experiencing bloody stools. At 1 year from radiation therapy, colonoscopy showed radiation colitis at the distal rectum. Biopsy was normal. You can see the radiation colitis right here and right here. And the patient was placed on sucralfate enema with plan for argon laser coagulation. He actually had the argon laser coagulation, but he still needs to use the sucralfate enema intermittently. So this is one patient who probably could have benefited from a rectal spacer, especially since he was treated with contemporary online adaptive techniques, he developed a grade 2 or higher toxicity. But these patients are probably fewer and far between. What is another controversy for rectal spacing? So another one is posterior extracapsular extension. This was a 78-year-old patient who had Gleason 4+5 disease involving 5 out of 12 systemic and 1 targeted core. He had radiographic T3A disease, and he was started on ADT. Like many of our patients in this area, he had an MRI that showed a 1.8 centimeter PIRADS 5 lesion in the left posterior lateral mid to apex peripheral zone with concern for ECE. And so as you can see here on the T2 sequence, you can see that this tumor is actually bursting through the capsule. It looks very hazy on T2, and it looks very dark on the ADC image, suggesting that the tumor is kind of really falling outside of the prostate. So for this particular patient who was referred for rectal spacer, the question is it really safe to give a rectal spacer for this patient? And the concern is that the rectal spacer could take these extracapsular cells and disperse them into the pelvic region, and these cells would not be treated with radiation. And so what it's important to know is that the rectal spacer was only prospectively evaluated in patients with predominantly localized prostate cancer. Even on the BioProtect trial, patients with posterior radiographic EPE were excluded. We don't know whether the rectal spacer may increase the chance for biochemical recurrence in locally advanced disease. And so this is one case where I would not recommend a rectal spacer if there's posterior extracapsular extension. What are some other concerns with rectal spacer? So one other concern is rectal wall infiltration. And what is rectal wall infiltration? Rectal wall infiltration is when the spacer actually gets into the rectal wall during the injection procedure. And how does it get into the rectal wall? It probably gets into the rectal wall when the spacer is being injected. Sometimes when it's retracted, if it crosses into that rectal fascia, it may get into the rectal wall at that time. And for the most part, the spacer procedure is safe, but if the patient is uncomfortable and they're moving around, they're lifting their pelvis, bearing down during the treatment, it might not be, some patients may actually have some spacer that goes into the rectal wall. And so there has been some literature on this. There's a grading system for rectal wall infiltration. In this case on the left, this is minimal rectal wall infiltration, where you can see that the rectal fascia is disrupted by the rectal spacer. Grade 2 is moderate rectal wall infiltration, where less than 25% of the rectal circumference is affected by the spacer. And grade 3 is severe rectal wall infiltration, where greater than or equal to 25% of the circumference has spacer within the rectal wall. And it's actually quite common. When you look on the MRI, the treatment planning MRI after the rectal spacer, which I would recommend that every patient get, sometimes you may actually see it in maybe 1 or 2 out of 10 cases, and that's actually what I've been seeing. So this was a case that was published back about 4 years ago. This was a patient, he had favorable intermediate risk prostate cancer. As we all know, it's a very curable disease. The patient underwent fiducial marker and rectal spacer placement by a radiation oncologist who had placed more than 200 of these devices. The patient underwent CT and MR simulation scan. And what they noted on the scan was that there was actually spacer that was present by behind the rectal fascia. So you can see this here on the sagittal image. You can see it more clearly on the axial image. Now, they didn't really detect this when the patient was undergoing treatment planning. They looked at this when there was a toxicity that I'll discuss to you later, but there was actually delamination of the muscularis propria. This patient was treated with SBRT. The dose was 45 gray and 5 fraction to a PTV that was the prostate plus a 3 millimeter margin. It's a very tight margin. The patient met all institutional guidelines, so the rectal V24 was about 33%. The rectal V39 was about 10% circumference. And what they found was that the patient had no acute side effects. However, at 5 months from radiation, the patient had worsening urinary symptoms, perineal fullness, anal pain, and mucus discharge. The patient went all appropriate workup for this. The patient had a cystoscopy that was negative. He had a digital rectal exam that showed anterior rectal wall tenderness. He had a sigmoidoscopy, which showed a large anterior rectal wall ulceration. And at 6 months from radiation therapy, the patient had to undergo a diverting colostomy. And the reason for this was that he had the dreaded urethral rectal fistula, where you can see contrast agent kind of extravagating into the rectum instead of just purely through the urethra. The patient had hyperbaric oxygen, and then I guess it was at 15 months, he had the rectal urethral fistula requiring permanent colostomy. Rectal wall infiltration is actually more common than what we would expect. When we look at the clinical trials, both the SPACE OAR and the Barrigel trials, as well as the BioProtect trial, reported that more than 90% of these spacer procedures were easy or very easy. And the degree of rectal wall infiltration was low in the original reports. However, recently there was a study that was published in Urology where they looked at the MAUD database. And what the MAUD database is that it's a database by the FDA where you can log major adverse events from medical devices. And this looked at SPACE OAR medical devices adverse events because this was the device that was FDA approved between 2015 and 2023. What they were able to see was that probably the rate of major adverse event was maybe about 1%. And this rate increased as the spacer became more readily utilized towards 2022, 2023. And what were the what were the adverse events that were reported? So some patients did not undergo the radiation treatment or had a delay in treatment. Some patients had rectal wall infiltration. Some patients had abscess and fistula, shock or sepsis, or even death from the rectal wall infiltration. So this can be an important thing to detect. If rectal wall infiltration is detected, especially if it's a grade 3 rectal invasion, this is one time where you may not want to proceed with SBRT. You can wait for 3 or 6 months if the patient is on hormonal therapy to see if it resolves, and then maybe treat with more IMRT type regimen. For patients who receive Barrigel, they can also undergo reversal. In this particular case, hyaluronidase can be used to actually break down the rectal spacer. So this is one patient who had the rectal spacer between the prostate and the rectum. This is the sagittal image, this is the axial image. And as you can see, there's a little bit of rectal wall infiltration. In this particular case, you can see that you can see some of the rectal wall actually going above the spacer. This is probably about a grade 2 rectal wall infiltration. And for patients where this is noted, it might be more prudent to try to put in the hyaluronidase, which can dissolve this big bleb, reduce that blood, make sure the patient is stable, and then proceed with radiation afterwards. So this is an image of the rectal wall infiltration that was observed on transrectal ultrasound after the MRI was obtained. You can see that there's a spacer here that's correctly placed. This is the intramural rectal wall infiltration. Hyaluronidase was placed into this blood, and you can see that the rectal wall infiltration was completely resolved, and the patient proceeded onto radiation therapy. So these are kind of some of the concerns with rectal spacing. Lastly, I want to talk a little bit about kind of my final recommendations for rectal spacing. All three formulations of rectal spacers can reduce rectal dose. Rectal spacers have been associated with a reduced acute toxicity for hypofractionated radiation therapy with the Barrigel product. It has also been associated with reduced late toxicity for patients receiving conventional radiation therapy, and this is with Space OAR. Optimal candidates for rectal spacers include those with localized prostate cancer without radiographic ECE, and continued vigilance is needed given rare chance of toxicity from rectal spacers. And that is critically important because, as we all know, prostate cancer is a very curable disease with a very low risk of death from prostate cancer. And so the concern is that if you have to lose your rectum from the rectal spacer, then that is a very severe event that we would want to prevent. So I would like to acknowledge the Brigham and Women's Department of Radiation Oncology, Dr. Orio, Dr. Nguyen, Palette Life Sciences, Barrigel trial investigators and patients, as well as all of the patients who participated in the randomized trials, and that gave us some better understanding of how these devices can help patients who are undergoing prostate radiation therapy, as well as the very few cases of patients who suffered from toxicity from the side effects of the rectal spacers. Thank you, everybody. I just want to see if you had any questions. Yeah.
Thank you for your comprehensive talk. In Taiwan, we started having spacer since last year. And more and more urologists are asking us about what kind of patients is suitable for space or implant. And because there are increasing early stage prostate cancer patients receive radio frequency ablation by our urologist. So I want to ask your opinion about implant space or for prostate cancer patients received radio frequency ablation.
Yeah, so I think that it's a very interesting avenue. People have thought about using rectal spacers for radio frequency ablation or cryotherapy, other techniques so that you get less energy into the rectum. The key is to see what is the level of evidence that supports placing the rectal spacer for those for those types of treatments. Are there any prospective data supporting it? And I feel that, without prospective evidence, I would not recommend it, or it should be done under trial protocol purposes only. Just because there might be some type of unexpected side effects that might come up, you want to be able to detect that in a prospective clinical trial.
And my second question is about proton therapy. Using proton therapy to treat prostate cancer has been debating for years under the concern of late rectal toxicity. And do you think combination of rectal space can make a change for this kind of situation?
Yeah, so I do think that there's a good rationale for using rectal spacers for patients receiving proton radiotherapy. And I do think that there is going to be less rectal dose when the spacers are used. The question is there a particular benefit for patients with proton therapy who have received the rectal spacer? And there have not been any prospective trials on that, although there's probably a dosimetric benefit and there could be a decreased amount of clinical benefit. But without randomized trials, you won't really be able to quantify that benefit. There was a recent study, it was presented at ASTRO in the plenary session by Dr. Stathiou, where they randomized patients to protons versus photon radiation therapy, looking at oncologic outcomes as well as rectal toxicity and bowel quality of life. And in that study, they actually stratified patients by the presence or absence of rectal spacing. They weren't able to detect a difference in terms of GI toxicity across those two modalities for patients in the spacer or no spacer subgroup. So it's still an open question.
Thank you for your comments.
Thank you. Any other questions? I guess how has the space OAR adoption been going in Taiwan so far? Have many of you had a lot of experience with rectal spacers? Maybe show your hands. Okay. Very good. So it's increasing adoption here. That's fantastic.
So is there any criteria for quality assurance for a spacer implant that we can provide it to our urologist?
Yeah, I think that's a really good question. The quality metrics that we have, so can I get my slides back up again? So I think that we did look a little bit about this at our, for our Barrigel study. And currently, there are probably guidelines that are looking at this. A couple of the quality metrics could be the symmetry of the spacer, and so whether it's actually centered in the midline or is it going off to the side. So for space OAR, the rate of asymmetry might be about 30 or 40%. Another quality metric could be the prostate rectum separation, especially at the prostate apex. And that can be because of, what we looked at in this study was the association of apical separation with bowel quality of life. But the third one is it's probably the degree of rectal wall infiltration. Hopefully that level is very low. If there is rectal wall infiltration that is detected, it's probably best to have it reviewed. Like if you see the rectum is a little bit fuzzy, it's probably good to just at first have it reviewed by a radiologist to see if they agree. You can also ask the patient to see if they have any symptoms. If they do have some symptoms, you could consider a sigmoidoscopy to see if there's any ulceration. You can consider an MRI to look, no, we've done the MRI, but you can do a sigmoidoscopy. And then at that point, if the patient is symptomatic, you can consider if they receive Barrigel, can you reverse it or not? Or you can delay the radiation therapy until the spacer resorbs. And so at about 6 months, that space OAR will likely resorb and then proceed with radiation at that time. You can also consider changing your radiation fractionation from SBRT to maybe more conventionally fractionated radiation therapy. And I think that could be also a safeguard if the patient has symptoms. But I think that the quality metrics, rectal wall infiltration, spacer symmetry, and prostate rectal separation.
It seems that rectal infiltration is the most fearsome toxicity. So is there any risk factors we can do patient selection or we should be aware during the procedure?
The rectal wall infiltration, the difficulty with rectal wall infiltration are probably more for patients who are thinner. They have less prostate rectal fat. And that's something that you can see before you try to put in the procedure. The other potential cause are patients that are really jumpy, and you wouldn't know that until you got them on the table. So, I do feel it's probably safer to do the spacer product when the patient is under some type of anesthesia, sedation, like max sedation. The other potential toxicity that has been also reported, unfortunately I didn't put it in my slides, is actually embolization of the rectal wall spacer. There has kind of been some warnings on that where the spacer product can actually go in to the lungs and you can lose the ability to breathe. And in those cases, it's important to make sure that the spacer is not in a vessel when you're injecting it and to actually put in some counter traction to make sure that there's no blood that's coming in the syringe before you put in the spacer.
I noticed that there was one grade 5 toxicity. And so it's due to infection or due to the emboli?
Those are probably the embolization.
Thank you.
All right, well, thank you, everybody. I think we're at time right now. And if you have any more questions, just let me know. Happy to talk more.